Okay, our next topic is HIV, and I want to begin by talking about the prodrome of HIV. Now, the prodrome of HIV that all patients get is a malaise, a low-grade fever, which is going to develop into an adenopathy and last anywhere between 1 and 4 weeks in the acute phase. Okay? Now, this prodrome is not the same as what we know as acute retroviral syndrome. Now, in acute retroviral syndrome, this is going to affect about 50% of HIV patients, can be up to 90%, but about half of the patients get affected with acute retroviral syndrome. And what acute retroviral syndrome is, it's a patient that's going to come in with a fever, a sore throat. They're going to come in with swollen glands in the neck, armpits, groin. They're going to have muscle and joint pains, and they're going to also come in with night sweats many times. And this is going to last anywhere between 2 and 4 weeks. So if you have a young patient that's coming into your office, what do you want to always ask them? Are they sexually active? If they're sexually active, what do you want to ask them? Are they using protection? If they're not using protection and they're coming into your office with night sweats and these symptoms, you want to consider acute retroviral syndrome, okay? But remember, that's separate from the prodrome that they normally get of malaise and a low-grade fever, because acute retroviral syndrome actually has a high-grade fever, over 100, okay? Now, how do we want to diagnose HIV? We want to do HIV serology via ELISA. And ELISA is going to take about 60 days to become positive. And if ELISA is positive, how are we going to confirm our ELISA? We're going to use Western blot to confirm our ELISA, all right? Now, if we've confirmed our HIV, what do we want to do? We want to treat, but we want to know what conditions we actually treat HIV in. Now, we're going to use something called highly active antiretroviral therapy, also known as HAART, highly active antiretroviral therapy, okay? And the time we're going to use HAART is in these conditions. And we want to know criteria for HIV. It's very important. If the HIV patient is symptomatic, if the patient has a CD4 less than 350, and in accidental needle stick cases, okay? So if you see these on the test question, that's when we're going to begin the HAART. And we also want to start highly active antiretroviral therapy if the patient is pregnant. Now, how do we know whether to start in the first trimester or the second trimester? Once again, it's very simple. We're just going to go to criteria, okay? We're going to look at the CD4 count. If the CD4 count is less than 350, we want to start at the HAART immediately, first trimester, okay? And if the CD4 count is greater than 350 and they have a low viral load, that's when we can wait till the second or third trimester to start them. So basically, if the patient's pregnant, make sure you look at the CD4 count and proceed accordingly. Now, prophylaxis is quite important for HIV. And the probably the most common they're going to ask you is PCP prophylaxis. And we're going to do PCP prophylaxis if our CD4 count is less than 200. So pneumocystis carinii pneumonia prophylaxis, remember, CD4 count less than 200, and we're going to start with trimethoprim sulfamethoxazole. Now, what's the side effect of TMP-SMX? Rash, right? So if you start TMP-SMX and they get a rash, then you're going to go to atovaquone or dapsone. What is going to be our prophylaxis for Mycobacterium avium intracellulare? Azithromycin once a week, okay? And when do we want to prophylax for MAI? It's when our CD4 count hits less than 50. That's when we're going to prophylax azithromycin once a week for Mycobacterium avium intracellulare. Okay, let's move on to opportunistic infections. Now, PCP pneumonia is probably our most common opportunistic infection. And how is the patient going to present? They're going to present with a shortness of breath, a dry cough, hypoxia, and an increased LDH. What's our best initial test for PCP pneumonia? Chest x-ray. What's our most accurate test for PCP pneumonia? Bronchoalveolar lavage. How are we going to treat PCP pneumonia? We're going to go IV trimethoprim sulfamethoxazole, and if you get a rash, we're going to go to IV pentamidine. Okay? So for our prophylaxis, we're doing the same thing, TMP-SMX. But in prophylaxis, if we get a rash, we're going to go atovaquone or dapsone. But for treatment of these opportunistic infections, for PCP pneumonia, we're going to go to IV trimethoprim sulfamethoxazole, and if there's a rash, we're going to go to IV pentamidine. And if the PCP is severe, we got to add steroids, okay? Now let's move on to toxoplasmosis. Toxoplasmosis is going to be the HIV patient with a headache, nausea, vomiting, and focal neurological defects. This is what we're going to look for toxoplasmosis. Now, what are we going to do initially to detect toxoplasmosis? We're going to do a head CT with a contrast. And how are we going to treat toxo? Pyrimethamine and sulfadiazine. What happens if we do the head CT and we're treating based on the head CT, we do another head CT and the lesions have become unchanged? Then we're going to biopsy these patients, okay? Because in this case, we're most likely looking at a lymphoma, okay? So if we do a CT and we treat the patient and the lesion's unchanged, we got to think of lymphoma, so we got to biopsy these patients. Next, a very high yield opportunistic infection, CMV. CMV is going to be the patient with HIV with less than CD4 of 50, less than a CD4 of 50, with eye problems. They're going to get blurry vision and pneumonia. Our first step, ophthalmologic exam, and our treatment is ganciclovir or foscarnet, okay? What we're going to do is maintenance therapy. We're going to do oral valganciclovir for life, unless with HAART therapy, the CD4 increases. Now remember, you can stop the valganciclovir for life if the CD4 increases with HAART, but remember, HAART with HIV patients is the only drug that no matter what, you're going to give for life, okay? So we're going to see the same thing when we do cryptococcus. Cryptococcus is going to be the HIV patient with a CD4 count less than 50, but they're going to come in with a fever and a headache, okay? So if you see a CD4 less than 50 with a fever and a headache, I want you to think cryptococcal in your differential, and you're going to do a lumbar puncture. And in this lumbar puncture, you're going to look for an increase in lymphocytes, all right? And our best initial test for cryptococcus is obviously India Inc. And our most accurate test for cryptococcus is our cryptococcal antigen test. How are we going to treat cryptococcus? We all know this. It's going to be amphotericin, right? But just like we did this for life, valganciclovir for CMV, we're going to go amphotericin and fluconazole for life. But what are we going to maintain the whole time? We're going to maintain our HAART therapy, a highly active antiretroviral therapy. And if our CD4 rises based on the HAART therapy, we can actually stop our fluconazole. But what's the rule? We never stop the HAART. That's going to stay for life. But if our CD4 rises, we can stop the fluconazole for life. And this pretty much gives the most high yield points I think that they're going to test you on HIV. I think it's also good to know the various drugs that they tend to test on HIV and the side effects that they can test on these drugs. And you know, a couple of examples would be AZT and how AZT can cause myopathy and bone marrow suppression. Didanosine, it's very popular for causing pancreatitis. And any of our protease inhibitors are Navirs. They cause hyperlipidemia and they cause hyperglycemia as well. And just try to memorize the side effects of our HIV drugs, because that's pretty much, other than the schematic right here, I think that's pretty much what they're going to target on your step 2 and 3, okay?